From Redox and Healthcare Strategy Bullpen, welcome to Diagnosing Health Tech, the show where we talk about healthcare and the technology driving it with the most interesting leaders in the industry.
Good afternoon or good morning, Health Tech. I'm Jeff Englander. I'm the founder and principal of Healthcare Strategy Bullpen. We are coming to you, or at least I am coming to you from New York and the Node Health Digital Medicine Conference. Good morning, Elizabeth. I am joined by our wonderful co-host, Elizabeth Ojo, who is a licensed pharmacist and co-host extraordinaire. Good morning, Elizabeth.
Hey, Jeff. Really nice thank you for having me back on this show. I really enjoy being on here. Calling in from not hot Atlanta, cold Atlanta this morning, but definitely excited to jump into our topics.
Yeah, we had snow yesterday. I was not expecting that. Well, we're going to depend on Namrata for the warmth. Namrata Rastogi is joining us. Namrata is a medical doctor, and Namrata is been kind enough to join us from California. Namrata is on the Health Advisory Board of Palantir Technologies. Namrata also is a former digital transformation advisor for the National Health Service. And we wanted to welcome you, Namrata, and just tell us a little bit about what you're doing currently, and then we've got a wonderful series of questions for you.
Hi, Jeff. Hi, Elizabeth, and hi to our audience. It's great to be here. Thank you for having me on the pod. I am in sunny California. It is a little bit warmer than Atlanta in San Francisco. So yeah, I'd love to share a bit about my background, what I'm doing at the moment, and let me dive in. So right now I'm on the Health Advisory Board at Palantir Technologies. As you mentioned, Palantir has a contract with the NHS to do various different care delivery projects. They ran the COVID vaccine delivery project for the NHS, and also have worked on other projects such as reducing the waiting list for planned care. They've also just won a contract to provide the federated data platform, which is a back-end data platform to run the health records for the population in the UK, and use that to derive insights and provide better care, better managed care for the NHS. You also mentioned that I was digital transformation advisor for a health system, and that's where the topic of today came about, the digital front door. I was an advisor to the NHS Frimley Integrated Care Board, and that role started during the pandemic to drive innovation within the health system.
Well, that's wonderful, Namrata. Namrata and I got acquainted during COVID. And, one of the things I found fascinating, Namrata, as you talked about what you did in terms of the digital transformation and the digital front door, was some of the research in terms of helping bring people in and understand some of the barriers they had to care, including both the digitally excluded and some of the work you did all the way down to interviewing the actual receptionists. And I'm wondering if you can talk about the breadth and depth of that work, and how you strove to understand, what clients and patients were facing.
Yeah, absolutely. So the UK primary care, it's a fully government funded service, and as a result there's a high demand on the services. We have an aging population. We have very small amount of funding per patient for each practice. It's about £163 per patient per year. So funding is limited, and then there's a shortage of primary care providers, and also a shortage of primary care trainees. There's a lot of infrastructure that's very archaic, and there's some inefficient administrative processes. And as a result, what we were faced with at the time of the pandemic was, queuing on phone lines, all appointments gone by 8:03 a.m. and misallocation of the available appointments that there were in the practice. And also physicians just burning out because they're just not unable to keep on top of the demand. And what we found was in the pandemic there was a mind shift in how we approach looking after patients from a digital perspective. You know, there was new policy reimbursement changes for consulting remotely. There was technology and infrastructure, computers, laptops that were delivered to practices to support communications. There were and also there was a movement towards remote monitoring, online consultations, and email communication between patients and clinicians. So I joined the innovation team leading digital transformation for the health system, which is a health system of 1.4 million patients. And there were 70 practices within that region. And the idea was to understand how we redesign our access points through apps, through the phones, through the websites, to enable more people to access care in a more efficient way, and identify who is not able to access care and design the system to enable them to get the care they need. So that's where the digital front door project came in. And what we found was we had some key pillars that we needed to address. So the primary one was navigation, and that was all about understanding who you can see as a patient entering the health system without waiting 3 weeks to see a physician.
Right.
So who was available to book directly as an NHS patient. There were counsellors, there were pharmacists, there were podiatrists, smoking cessation advisors, midwives, health visitors, all these clinicians that you could book with rather than waiting 3 weeks. So that really helped to move people to the right place at the right time. And then there were also opportunities for social determinants of health. So what else could you access? You could access community resources such as housing associations, citizens advice, job opportunities, jobs boards, job centres, all those sorts of things. And then relevant health information. So we wanted to provide on our websites an approved apps library, so verified health information, trusted resources for conditions. And so we wanted to understand which apps were HIPAA compliant or the equivalent, which is DTAC compliant, and get those to patients so they could get that relevant information, and then optimize the use of the appointments on the ground that were available for people to come in who needed to be seen, and optimize the appointments of people who could be seen remotely or people who needed to be seen in their home.
That really sounds like a Herculean task. Now, how did you mentioned kind of steering people to the appointments that were available. What was involved in kind of figuring out, okay, if someone was really coming in to see maybe a primary care doctor but needed smoking cessation, how did you figure out to make those visible and available to patients and to let them know that they could kind of skip that initial step and, as I think we talked about in the pre-call, maybe go to physical therapy or maybe go to directly to an MSK doctor? How did you to figure out to let them know that those slots were available?
Yeah, so there were multiple ways that we shared the transformation work that was going on in the health system, and everything from advertising on our websites, advertising in our waiting rooms, the receptionist on the phone talking about the new digital front door and navigation systems. And the other thing that we did was we invited a patient participation group. So a patient participation group involved about 20 people from our practice population. The practice population of my own practice was 8,500 patients, and they would meet quarterly. So they were people from a diverse range of ages, ethnicities, cultures, occupations, and health conditions, and we would invite them and engage them in understanding what we're trying to accomplish here and get their feedback on board about what kind of health services that they would like to access and where the unmet needs are in the community. And that really helped to spread the transformation work and encourage people to use the new ways of working to access the care.
Elizabeth?
That was actually going to be my question, Jeff.
Okay.
But I do no, but Namrata, I'm really, I love hearing the excitement that you have for this, and I, love this mission that you have of, intelligently not only matching patients to the available providers that are available for whatever service they need, but also actually advertising, right? That these are now options that people can have, because a lot of patients reflexively will pick up the phone and want to talk to someone, but may not be understanding that they can go on the website or have other points of access to these appointments. So I love this advertising campaign that y'all undertook. Can I ask a little bit, what structures did y'all put into place to sort of measure outcomes, right? Like, as these points of entries are changing for patients, did you have some sort of way to measure whether or not patient outcomes remain the same or better, even as we're adopting, digital forms of care and things like that?
That's a great question. So going back to Jeff's question as well and tying that in with what your question is, we wanted to understand who was able to access care within the population and who was not able to access care within the population. And so we were fortunate to have a data analytics software for the patient population for the 1.4 million people, and we could understand trends. So we could, from that data, identify at the beginning of the project that 6% of the population in my particular practice were excluded from the digital work that we were doing.
That's a lot of people.
Yeah, and so then it was a case of understanding, well, who are those 6%? Is it because there are older people? There are various different reasons why you can be digitally excluded. It could be age, it could be English not being your first language, it could be inability, like lack of computer skills, it could be homelessness. And so we really needed to break that down and identify who those people are. And the incredible thing about it is when you work in a rural practice, your receptionists actually know who exactly those people are by name. So
even with the patient population that you mentioned, 8,400, that seems like an awful large panel size.
Yes, I mean, we've had receptionists at the practice for 30 years.
Wow.
So they do know the people who come in and have a chat, and people use the phone rather than the internet. So but in any case, we did use tech to identify those people and then design population health interventions to get those people accessing care, and then remeasure the digitally excluded population based on our interventions. So there's been some really interesting work at the health system on improving access. And I'd just like to share a couple of those interventions.
Yeah.
So one of them was in a particularly deprived area in the patch where digital literacy was very low. The health system funded digital literacy classes to teach people how to use computers and tech and how to access the primary care resources that we were building. So these were computer classes hosted in the library where people could come and learn for free about how to use their technology, and then continue to use those resources, the computers and devices, to access their care, or bring their own smartphones and learn how to use them to schedule appointments and book appointments. So that was one about improving digital literacy, and there was data to support significant improvement in technology skills at the end of the project. It was 3-month intervention. The other thing is identifying who has connectivity and who doesn't have connectivity, and who's using a smartphone versus Wi-Fi, and enabling connectivity for those people. So we found that a lot of people needed to use, had phone access, but no connectivity. So we needed to make sure that all services that we were trying to provide for patients were available on the phone if they couldn't use computer or a data device, and that's where full functioning capability was built in terms of even the navigation work that we did. We built a care navigation platform that was specifically tailored to navigate and triage people through the phone systems. And I can talk more about that in a minute because it's quite an interesting project we did about design thinking. But just going back, staying with the digital inclusion, we also identified that we had a huge Nepalese population in our area, so English was not their first language, and as a result, we could see they were not accessing appointments for, say, diabetes care, or they weren't accessing services for, say, menopause care or heart disease. So we could see that the appointments weren't being used by these people whose first language was Nepalese. And as a result, we implemented a training day or education day where one of our trainees who spoke Nepalese as a first language invited all the Nepalese community to come to the practice and go through chronic disease management, go through opportunities to engage with the practice, and how they can book a translator if they want to come and see a clinician. So some really interesting projects that were going on. One other thing which is super interesting, I think, is using non-traditional healthcare providers to provide care. So I'm talking about things like community faith leaders to deliver health interventions, or food banks or food delivery companies. We found that during COVID, vaccination uptake was low in certain pockets of the community, and by delivering nudges or education in these places where people were attending,
meet the people where they are, like where they actually hang out.
Exactly. So that helped to increase COVID vaccine uptake by educating people in their communities, by people that they trusted, about what the vaccination involved and how they could access those appointments.
How can you, one of the things we actually just talked about here at the conference was building trust with public health officials. And one of my great frustrations in a project we worked on was that there's an over-reliance, at least in this country, on surveys, whether it be an email survey or an actual hard copy mail survey of, hey, how did you like your doctor's visit? Please rate it 1 to 5. And when you try to do that in your communities, you get nothing, or you'll hear from the person who's most disgruntled. How did you bring those people? How did you bring community leaders into your fold, and how did you get them or bring in their trust and say, hey, help us? You're really the group that the community looks to, and particularly with the vaccine where there was some skepticism.
Yeah. So one thing is to ask the patients, to go out and ask them, who do you trust? Who do you want relevant health information from? We've seen this with the MMR vaccine and the reduced uptake in primary care. And what they told us was they want, in that particular population, it was the mums who wanted more health education about vaccines. They wanted information from a doctor. But in the COVID vaccination situation, they wanted information from someone who spoke the same language. And it's really about going out and asking them, what is the reason that you haven't taken this vaccine? Can we help you understand it better? And providing information in a language that's that they feel comfortable in was the primary reason for not having done it already. So it's really interesting what you find out when you go out and talk to your customers. But community leaders, there are various organisations in the UK that help you find the right patient population, the right leaders and the right patients to help you. There's a patient advocate groups that you can engage with that represent communities and tap into their skills and experience.
Interesting. Did
I
you have a follow-up, Elizabeth? Or go ahead, Namrata. I'm sorry, I didn't mean to interrupt.
I just want to go back to your point about the receptionists and engaging
Please.
in design thinking. So as part of the telephone triage project that we did in the practice, it started off in our practice with 8,500 patients, and the idea was that if it works and if we learn something, we'll scale it up to the health system for 1.4 million patients. And what we built was we started off with design thinking, and design thinking is something that I learned at Stanford on the MBA program, which is going out and understanding the pain points of your customers before you even begin to build a solution. So you can really understand what the problems are and build something that's tailored to their needs. And so for that reason, I started off with the receptionists in the practice, and I said, okay, we need to build a care navigation tool, supposedly. If there was such if there was such a product, what are the biggest pain points that you as receptionists face on a daily basis when you come into work in the morning? What makes your work challenging? What makes your day hard? What keeps you up at night? And so they would list 10, 20 issues, appointments gone by 8:03, or aggressive patients on the phone, or not being able to speak to the right clinician to get some advice at the time that they need it to make a decision about what to do with that particular patient on the phone. And then, so that was one pocket of data. And then it was, what do you think are the biggest challenges that the patients are facing? What do they tell you when they ring up? What are they most, what kind of conditions are they calling for? What are the common things that they ask? And so that was another pocket of data. And then it was, okay, so what do you think the biggest challenges that the physicians and admin team are facing in the day-to-day running of a primary care practice? And that was, a huge administration burden, spending an extra third of time doing notes at the end of the day. So we mapped out all these pain points, and then as a result came up with a navigation tool that would prompt the receptionist on, for any condition they put into the tool, services that were directly available for the patient to book themselves or without a GP appointment, and also how, for each condition, how quickly to prioritize that person being seen. Do they need an urgent appointment on the day, face-to-face with a clinician? Can they send an online consultation through the website, which will go to an admin manager and be dealt with within 24 hours? Can they submit a prescription that will get signed off within 3 working days? So it was a comprehensive tool that was built on the needs of the practice, that we then piloted out to see if we had really understood what problems we were solving.
It really sounds like you were incredibly thorough and incredibly solicitous of people, which I think is really necessary. Elizabeth, did you have a follow-up, or?
I had maybe a different question.
Go ahead.
I wanted to go in that route. I'm really curious to hear, Namrata, because you mentioned earlier, one of the main issues we're trying to solve is that clinician or physician burnout, right? And I'm really curious to hear what material effect that this, new increased patient access and navigation or smart routing has done, because I feel like there's almost this paradox of we increase patient access, right? And maybe route them to mid-level clinicians or other places where they can get their information. But the people whose schedules were full in the past are probably still full today. So I'm curious to know if there's been any material effect or any measured effect that you've seen to improve that kind of burnout that you were seeing previous to this solution.
Yeah, that's such a great question. And I think the important thing to realize here is we are working against an uphill battle. So the more we implement new technology and software, we're also continuing to face funding shortages. We're continuing to lose clinicians. Nurses are leaving the profession, and so each day, even though we implement software and technology to try and make things more efficient, we are facing an uphill battle. But I do think there has been an improvement in morale, an improvement in well-being, within an improvement in, say, stress levels between the clinicians from having these tools to support them in, and also having a supportive workforce that collectively manages care.
That's good.
It is tricky, and it's not measured in an objective way.
Right.
What we have seen is, for example, implementing an AI automation platform for a back-end administration. We purchased a software that would automate new patient registrations. So it was a software that was brought into the practice to automatically register new patients. That would save the admin team 5 hours of work in a week. And so it's just been implemented, but it was an objective measure of reducing workload. And as the platform develops more capabilities to automate back-end administration, we should see a reduction in workload for our admin teams. So it's incremental,
right?
And but there are points to measure the efficiencies.
So, Namrata, I have a little bit of a separate question as well. There's a tendency of clinicians to kind of look down on marketing and marketing research and some of the design thinking you even talked about, but that seemed to be incredibly beneficial. How did you incorporate or recruit the physician support for what you were doing? Because in the end, it seemed to be incredibly helpful to them. But initially, I imagine there was some resistance, and I'm wondering if you can talk about that.
That's such a great point. Yes. So not everybody is as excited about technology or new technology or changing the way that we do things, particularly if it's been done a certain way for 30 years. And so there is a lot of work that needs to be done in key stakeholder engagement. And I think what I've learned is, first you have to engage them from the beginning, and you have to engage a diverse team. So building software is not just about clinicians, it's about the admin teams, it's about the chief technology officer, there's a digital change manager, there's patient participation groups, there's you have named digital champions in your community. So it's about getting around a table together and understanding what we're trying to solve and why we're trying to solve it. And when there is purpose behind what you're trying to solve, people get on board and say, okay, I'll try it. And but you have to be prepared to pull back and say, okay, this didn't work, and I'm sorry that it was a technical it didn't go as planned.
Right.
To give you an example, we implemented a piece of software for our triage. So a platform that could help us triage the sickest patients and flag them to clinicians sooner. And the platform didn't integrate with our EHR. So on the day it was implemented, we had a problem where it didn't integrate. And for our clinicians and for our admin teams, the idea of them having to manually copy and paste consultation that the patient has provided on the website or the app and saving it in the record was a huge administration burden. If there are,
I imagine you were very popular that day.
Yes, you have 100 contacts a day from patients in your practice, and you have to manually copy and paste them into the records to save the information, to do anything about it. That's unacceptable administration burden. And you have to be able to say, look, I'm sorry, this wasn't the right thing. We missed it. We thought it was going to be addressed in time for implementation, but it hasn't been, and we're pulling out. And you have to respect your colleagues and say, okay, like, I'm sorry that we have put you through this training for this piece of software, and we're just going to shelve it and find something better. So I think being honest about it and saying, and not putting them, and understanding there.
Well, and willing to admit when something's not working. You know,
Yeah.
I think that's very admirable. You know, willing to unplug the software after you've seen it's not working. I think there's a lot of, you know, really high up people who wouldn't have admitted, right, that they made a mistake. So really hats off to you and your team.
Yeah.
Thank you.
One other question that I had was, were there any discoveries you had in terms of either design thinking or the project overall that were surprising to you, either positive or negative?
Oh, that's a great question. For me, I think the most surprising thing was how I was really excited about how much the patients were willing to adopt new technology and
That's great.
change. And they were, you know, they wanted to text to or use online consultations, and there was like that shift of going from calling up to sending an email or sending an online consultation. They were very receptive to, here we have this new platform, please fill out the query and we'll respond within 24 hours. You know, that willingness to change as we implemented new software and engage with it was really amazing.
Interesting. And one last question, and you know, while we're queuing this up, I'll just ask if there are any questions, you know, from the audience. If there are, please feel free to, you know, pose your question to Namrata. But one last question from me, and then apologize, Elizabeth, I've been dominating. If there's anything you wanted to add, Namrata, what would you advise someone, you know, who is going to take this kind of initiative? You know, from your experience, any particular advice you would give them?
Do you mean as someone who wants to implement digital transformation within their?
Yeah, like a digital, someone who's starting or has you know, is not satisfied with what's going on with their digital front door. You know, yeah. What would you tell them to do?
Go out and talk to your patients, go and talk to your workforce, your team, and understand where the pain points really are.
Okay, great. Anything from your end, Elizabeth?
I think maybe one last question, if that's okay. Speaking of pain points, I'm curious if you've noticed specific challenges that are unique to, you know, for the UK versus the US. If you've noticed any trends or specific something surprising in the ways you know, the US and UK may handle patient navigation or digital transformation. I'm curious to understand if you've seen like any specific differences or something that surprised you between the two different countries.
Yes. So the main difference is the billing and reimbursement.
Oh, yeah.
So in the NHS, you want to be as efficient as you possibly can. Yeah. Your primary care there's funding for £163 per patient per year. Very limited. There's a huge shortage of appointments, and you want to be getting that patient to where they need to be as soon as possible. And you want to enable them to help themselves. In the US, where there's reimbursement and reimbursement at every stage, there's a tendency to bring people in, have more than one consultation with a provider, request some investigations that may not be as necessary, and so there's a balance between helping people to get where they need to go and also providing them with a higher level support and sending them to one or more provider to get them to where they actually need to be.
Strange, the US is a little more complicated than the rest of the world. Shocking. Well, Namrata, we really want to thank you, and we really appreciate it. Thanks so much, for your time and your insights,
Yeah.
and look forward to connecting with you again. And I know I will see you out at the JP Morgan Healthcare Conference in a couple of weeks, and I'm super excited about that.
Thank you. It's great to be here.
Thank you
Thanks
so
very much. So with that, we will move on to our quick takes. And in our quick take section, we're just going to talk about a couple of stories, handful of stories that are in the news today. First is CVS plans to overhaul how much drugs cost. It's a story from the Wall Street Journal. CVS is switching to what they call a cost plus payment model. They're going to call the payment model CostVantage, where CVS retail pharmacies and other payers will be paid based on the amount that CVS paid for the drugs, plus a markup and flat fee to cover the services involved in handling and dispensing the productions. This will be phased in starting in the first half of 24, first for people using cash and a discount card, much like Mark Cuban's company, and then in 2025 for employer plans. The company is responding to criticism from lawmakers, employers, and patients about the complexity and the difficulty in figuring out how much or lack of transparency in how drugs are bought and sold. CVS and other middlemen are looking for ways to stem the tide of regulatory backlash on drug pricing. This may help. My feeling is that there will be severe or more regulatory consequences, particularly in the U.S. Or particularly in this Congress in terms around drug pricing. Next story was on AI from Politico, driving Google's healthcare business. Washington doesn't know what to do about it. And the crux of the story was Google wants to make your cell phone a doctor in your pocket that relies on the company's artificial intelligence. Google has assembled a very potent lobbying team to influence the rules governing AI just as regulators start writing them. Congress and competitors are concerned the company is using its advanced AI in healthcare before the government has had a chance to draw up guardrails. Competitors, particularly small ones, worry that Google is moving to corner the market and to help fashion the rules that would be easy for large companies like Google, Amazon, and Microsoft, where we are today, to fashion the rules. In particular, Google is piloting AI with Mayo Clinic researchers. They have an assistant with HCA Healthcare that's using to write clinical notes for physicians and nurses. And unlike Google's partnership with Ascension, they appear to be trying to get ahead of the problems they had with regulators before they arise. The concern from regulators and legal experts and startups is that AI will infiltrate healthcare before legislators can really get their hands around it. I think that is true. The technology is moving so fast that it's virtually impossible for legislators to keep up. There's commentary here today that there are only 3 legislators in the U.S. Congress actually have any formal education around AI. One of those is in school now. So I think it's going to be very difficult, for Congress to keep up. I think there'll be a pendulum swinging the other way. You'll see some regulation that may be overkill. I would say that the companies, smaller companies should, and the industry as a whole, should stay vigilant for some overreaction. Also, changes in physician electronic health record use with the expansion of telemedicine. Some informatics researchers from UCSF found that both during and outside of scheduled hours, an uptick in telehealth required the use of ambulatory physicians to spend more time working in the EHR. The overall time ambulatory physicians spent documenting EHRs during physician working hours increased from 6.35 before the pandemic, to over 8 in September 2021. And the crux of the article is that policymakers and system leaders need to keep these demands and clinicians' times in mind as they look at future reimbursement models and workflows. I think this is incredibly important because I think the reimbursement schemes to date have been based a lot on cost economics and the economics of whether you're actually in a physical office and you have assistants and others helping you. And I think they need to shift to more to the value that's brought to these appointments and how they can steer patients. And I think there'll be an ongoing debate, but I hope to see more reimbursement based on the value of telehealth and other digital health tools. Showdown here, the FTC chief was tough on private equity's takeover of healthcare. The FTC and DOJ signaled they'd apply more scrutiny to private equity acquisitions in healthcare, including so-called roll-up deals in which a large provider groups buy smaller groups in the local market. What they're talking about here is PE acquisitions of physician groups when recent years have moved about concerns about the mounting impact on healthcare costs, quality of care, and providers' clinical autonomy. There was some commentary, that this is a pretty common roll-up strategy from some folks at the Brookings Institution. The FTC has been pretty lax on monitoring these roll-ups, as there is a dollar limit, and it's right now about $111 million, and the threshold has not been adjusted. We do expect more focus from the FTC and DOJ going forward. There's currently a lawsuit against Welsh, Carson, Anderson, and Stowe. And we would expect this to be an area of additional scrutiny. We do expect the potential Cigna deal with Humana, if there is one, to face additional scrutiny, and it could face some tough sledding. And last but not least, 23andMe confirms that the hackers stole ancestry data on 6.9 million users. In this case, it was a really interesting story. Hackers accessed to personal health information of about 5.5 million people who opted into 23andMe's relatives feature. The stolen data included the person's name, birth year, and relationship labels. What's interesting about this, in December, 23andMe disclosed that the breach only affected about 0.1%, of their customers, or 14,000 people. But in reality, the breach was known to affect roughly half of the company's reported 14 million customers. And I think the crux of the story here is it's important to understand before you go public and before you talk about the full extent of the damage and how to control this before you go public and what data has been released. So I think that's really important and really a lesson there. So with that, let's shift to our articles for discussion, and we'll bring Elizabeth back in. Thank you for your patience there, Elizabeth. Quite a number of articles. First article, which I know is of interest to both of us, is what it's like living with limited access to internet in the rural South. And this was a wonderful article from the Markup about the lack of progress in getting internet in the rural South. And one of the things they talked about, certain areas in the rural South, as many as 30 to 35% of people really lack internet access and have difficulty when they do have access, getting quality internet access. And I think it's really a national tragedy. Wondering what your comments would be here.
Well, I think these numbers would really surprise people. I mean, imagine if a whole portion of the US didn't have access to running water. The access to internet is just as important as necessary in today's moving and fast-paced world as I would say just about any other resource. And it is a shame that time and time again we see a trend in certain states that they are just behind in making that kind of progress, especially for their marginalized for these marginalized communities, because you noted there's about 30 to 30% of these households in these rural southern states don't have access to the internet. But of course, that percentage is higher for minority groups, especially the Black residents who live in these states. And I think truly it's an embarrassment. We saw that. Yeah, go on.
No, I'm just agreeing with you. I think it's an embarrassment.
Yeah, we saw that President Biden has made available some funding to hopefully be able to address this specific need to implement the broadband access for these communities. I think at this point, and I know that the funds are being dispersed over the next few years, but I would say that if these community leaders wanted to, they could have done it by now. I mean, it's 2023, basically 2024, and these communities are basically having to live as if we're in the 80s or something before this became ubiquitous.
Yeah, and I just want to add, for people who think, okay, maybe this is with a specific cell phone company, or maybe this is just a specific person or, strange particular community. As everyone knows, and fans of the show, my son was a reporter in rural Louisiana, a town called Monroe, a very small town. And as a reporter, he's given a device which has access to Sprint, T-Mobile, AT&T, and Verizon. So he has effectively the best cell phone you could possibly get. And I asked him once, I said, what percentage of the time don't you get access? And he said 30 to 40% of the time he didn't have access to a signal. And so it's not just in a particular company. And the other thing is this was happened in multiple communities. And I think the important thing is for providers and payers and others, you have to think about this when you're looking to deploy remote patient monitoring solutions, virtual health, and you have to think about not only just access, but how thin or thick, so to speak, is the throughput of the system you're trying to deploy. Might you need to deploy something with store and forward or something like that? Because these are issues that you do have to deal with.
Yeah, absolutely. And of course, as we see time and time again, without access to internet, right? That really puts these communities at a disadvantage for just about everything. Education, healthcare, telehealth services. These workers likely aren't able to work remotely, even if they wanted to, because they don't have reliable access. So this is by no means a problem of yesteryear, right? For hospitals and health systems and employers to take into and educators to take into consideration that a lot of the broad swaths of the population just don't have access to these tools and resources. And perhaps if that education is being put out there into the community, that may put more pressure on those people in leadership, on these supervisors, to maybe start implementing solutions, hopefully, because I'm sure communities are used to not having access to the internet. I mean, they're probably just used to it, and it may take a stronger advocate for them to maybe get them that access that they need, that their leaders are denying them, frankly.
Yeah, no, and the one thing I will add is I think there is a role for healthcare to play here in terms of partnering with public education, I know in Louisiana there is several initiatives where some of the public education officials and public health officials and the local hospitals were partnering, trying to set up both clinics and broadband access points at local libraries so people could at least have access there. So I think that's hopefully at least a start. In our second article, just talking about the fact that depression is costing the global economy, according to the U.S. Surgeon General, a profound $1 trillion a year, and also a bit of a depressing article. Sorry to be a downer before the holidays, and happy Hanukkah tonight for everyone who celebrates. The one thing I would add is some commentary around the shortage of providers and the ability of people to get care. I do think we're looking at ways with digital health to provide more and more tools, and wondering from your perspective and from Redoc's perspective, what are some of the things that can be done to address this, Elizabeth?
Right. Well, first of all, I'm really glad that this article is out here, because we know the kind of society we live in where money talks, right? And the profit motivator is, the number one priority for a lot of employers, which is absolutely fine. And, that's how our society works. So I really hope that HR departments and resource departments and employee resource groups departments all over the US can now point to this research, right, and advocate on behalf of their employees for more resources, right, for more either for more budget or whatever is necessary in order to address this however they see it within their employee group, be it easier and greater access to mental health practitioners, ability to maybe give people additional time off as necessary, just like we have sick days. We need mental health days, not only introduces the workplace, but destigmatized. And hopefully, this when we can see the hard numbers that, hey, we're also losing out on that slice of $1 trillion of lost employee productivity due to untreated or unrecognized mental health problems. This is the proof that we need to say we need to reinvest into our employees to make sure that, for better or for worse, that we're reaching the most productivity and the highest possible profit we can through a healthy workforce.
Yeah, no, I absolutely agree. And I also know that, this time of year in particular can be a difficult time for people. And so I do encourage you, if you are struggling, please do reach out, either formally, to
Absolutely.
988, to a friend, to anyone, if you're particularly a young person struggling, reach out to a parent, reach out to a friend's parent. This is you're not alone. There are people here for you. So please do, reach out to the appropriate resources. They are there for you. So with that, I will thank you for joining us. This week's blog at Healthcare Strategy Bullpen is, AI and anesthesiology, lowering the risk of surgical complications and adverse outcomes. So I do encourage you to, sign up, obviously, for Diagnosing Health Tech, as well as for our blog. There's a QR code right on the screen for you to sign up. Please do check us out at Healthcare Pen on Twitter. Check us out on LinkedIn. We are at Healthcare Strategy Bullpen. We like to think of ourselves as a Rosetta Stone between the culture and language of healthcare and technology. We help you adapt and deploy healthcare tech to improve the lives of patients. Thank you for joining us, and we will look forward to having you here next week. And with that, I will turn it over to Elizabeth.
Thanks, Jeff. It's a great show. Hey, everyone, feel free to subscribe to the show, Diagnosing Health Tech, by scanning the QR code on the screen. You'll get weekly invites to the show. And just want to give you a quick reminder that this show is also sponsored by Redox, the healthcare integration platform that specializes in the implementation of big data, AI, and cloud computing. From all of us here at Diagnosing Health Tech, thanks for watching, and we'll see you next week. Bye.